My presentation is on Candida auris. So the taxonomy is domain Eukarya, kingdom fungi, phylum Ascomycota, class Saccharomycetales, family Saccharomycetaceae, genus Candida, and then species is Candida auris. There are two different scenarios that Candida auris can cause. The first scenario is an invasive infection, which is going to be a systemic fungal infection, or the person's going to be colonized and it's going to live on their skin without causing any symptoms of an infection. Candida auris is very hard to identify from other species of Candida. It's a yeast. It's going to look like other species of yeast. You can see on the left of the slide on this plate, in the red circle, that is Candida auris. And then on the plate is growing some other species of Candida, and they all look very similar. So it was very hard to identify this species. This species of Candida was first discovered only in 2009. So it's definitely an emerging disease because it is spreading rapidly. This map here shows the known cases in 2017 in the US. And then this map here shows a jump to 2022. So you can see it has spread pretty rapidly in just a few years. And that is 2 years ago, so the numbers today are definitely much higher. At my own hospital, my unit was shut down for 10 days because 4 of our patients tested positive for Candida auris. And this is why I did pick this for my presentation. We had to completely deep clean my entire unit, and we had some losses. Unfortunately, one of our patients did die, I think within a week of being swab positive, and he was only in his 30s, so it was sad. So Candida is spread through direct contact or indirectly with fomites, and I think this is one of the reasons why this is spreading so fast and hard. Is you can see on this some of the studies coming out to show how long this is living on certain fomites, and you can see on plastic it can survive over 14 days alone. This particular organism is an opportunistic pathogen. This means it is not going to affect healthy hosts. It is going to be very concerning for immunocompromised and chronically ill patients. Healthy individuals can be colonized with this, but it will not cause symptoms. The symptoms for systemic infections will be similar to those for septicemia and sepsis, be fever, chills, low blood pressure, tachycardia. If the patient has respiratory compromise, it's going to be very hard to keep their oxygenation status stable. And this has been especially concerning in my unit because we have trach vent patients and they rapidly develop superinfections and become very ill once they have been swab positive. Also, it's difficult to say if Candida auris has been the cause of death or if it's the original illness that is the cause of death in these patients. Healthy patients do not develop these complications, though, so it is important to realize that, again, this is an opportunistic microorganism. You have to worry about your chronically ill, immunocompromised patients. Healthy adults, again, usually they are colonized. Yes, they can have this microbe, but they're not going to develop these complications and invasive invasive systemic infections that immunocompromised patients are going to develop. Treating this species of Candida is very hard. It's known to be multi-drug resistant, and as you can see on this slide, more than 1 of 3 patients with an invasive infection will die within a month. But again, I will reiterate that most of the times it is going to be difficult to definitively say whether Candida auris was the cause of death or if it was the original illness that caused the death of the patient. So once you have been colonized with Candida auris, it now becomes part of your normal microbiota. This means it is now a part of you. I have spoken to our ID team about this personally. For now, this has not posed any known health risks to healthy adults. My personal concern is whether or not this is going to pose a risk to us in the future should we ourselves become immunocompromised in the future. But since this microorganism is so novel and the scientific community has not had time for proper long-term studies of this microorganism, these questions are going to need to be answered. But again, this is now, once you have it, it is now part of you and you are colonized with it, it stays with you. So the treatment is aimed at prevention of spread. So this is mostly by proper, again, hand hygiene. Before and after you're putting on your PPE, before and after every patient interaction, disinfecting all patient rooms and surfaces in your healthcare setting. And once a patient is swab positive, they are always positive, no matter how much time has gone from their positive swab until you get them back in the hospital. Every subsequent admission, they are positive, so they're always going to be in contact isolation precautions. So if they swab positive today and they are discharged and they come back 3 months later for a new admission, they are still put in contact isolation. All of the precautions are put back into place again because they are still colonized as normal microbiota. We don't swab them again, we just place in their chart. Once swab positive, you are always positive. And here you can see what contact precautions are. You're going to perform hand hygiene before and after donning and doffing your PPE, which means, yes, wash your hands before you put your gloves on. And after. Everybody washes them after you put your gloves on, but you got to wash them before you put your gloves on. So you're going to put your gown on and gloves for all patient interactions, and you're also going to disinfect all rooms and equipment, all surfaces after the patient is left. We actually have an entire checklist just for our Candida auris patients. After they leave or are discharged, we take everything out of the room and all supplies, anything that can't actually be disinfected has to be thrown away. And this means like open boxes of gloves. So we are very careful even to maintain while they're in the room for their hospitalization, not to bring too many supplies in to be wasteful. So we don't stock the rooms while they're there because we have to throw away a lot. And then if they're being transported at any time during their admission, they're going to need to be covered with a clean sheet for transport. And here are my references. And I would personally like to thank Kathy Arison with our infection prevention team at Summa Hospital. Thank you, thank you, thank you. She is a wealth of information and she has dedicated so much of her time to help us all understand how we can all make a difference in preventing the spread of this particular microbe.